segue to asthma biology. And there have been a lot of good studies, especially in the last 2 years, looking at, thank you, asthma biology. Um, Prenatal and early life exposures are known to um, are known to play an important role in the development of asthma across the lifespan and in the developing immune system, as well as lung structure and function. So we know that bronchiolitis in early life is a risk factor for subsequent wheezing and asthma, presumably leading to long-lasting changes in the airway size and structure, along with alterations in mucosal immunity. And several recent longitudinal studies have been published. Dumas et al. Is one of them. And this one used a clustered approach to studying different types of severe bronchiolitis in infants and studied their relationship with childhood asthma at 4 and 7 years of age after hospitalization. And they found the highest risk of childhood asthma is observed in children with a history of wheezing and eczema prior to bronchiolitis episode and wheezing during acute illness. As we look at other studies that explore prenatal and early life origins, pollution and prenatal air pollution exposure has been associated with the development of asthma and allergy as well. So this is a study that was published in Pediatric Respiratory Reviews, and it's very small, the print, but this was looking at the impact of maternal asthma and fetal lung development, outcomes, mechanisms, and interventions. We know that asthma affects up to 17% of pregnancies worldwide. And maternal asthma is a strong predictor for asthma and, maternal asthma is a stronger predictor for asthma than paternal asthma. In addition to increased risk of pregnancy complications, maternal asthma in pregnancy increases the risk of transient tachypnea of the newborn, respiratory distress syndrome, and reduced lung function at 5 to 6 weeks. So these adverse impacts persist in children of asthmatic mothers, and they're more likely to have asthma, wheeze, and pneumonia, as well as upper respiratory tract infections. So in looking at the mechanisms for impact of maternal asthma on fetal lung development, it is complex. It involves lung-mediated changes, immune cell-mediated changes, as well as placental changes. And if you look at some of the interventions that they list in this article, it includes using steroids antenatally, vitamins A, C, and D, as well as having moms to control their asthma during pregnancy. So there are also implications for diet and asthma. And so this study looked at effects of dietary interventions on markers of type 2 inflammation and asthma. And in children, we know that atopy is associated with food allergy, but there's less known about adults and the role of dietary interventions in asthma. So in this study, they looked at different dietary habits and whether or not there was a decrease in type 2 inflammation. They concluded that the current evidence does not support a specific dietary intervention to improve T2 inflammation, but there were certain interventions, including phytotherapy, which is herbal remedies such as Nigella sativa oil and omega-3 polyunsaturated fatty acid consumption that seem to have more of an impact. So a lot of my patients do ask if there are any dietary changes that they can implement. So you may discuss with them some of those things, but across the board, there was nothing that specifically dramatically decreased asthma and T2 inflammation. So again, as you look at asthma biology, this is something that we have to acknowledge plays a role in asthma development. This study published in 2024 in May really nicely shows the different aspects of asthma biology that are being studied. Prenatal and early life origins we looked at. Epigenetics is a new area. It's the study of gene expression and the way genes bring about their phenotypic effects. Also, the microbiome is increasingly being looked at in asthma and health outcomes environment, including in the workplace and air pollution, as well as the lung-brain axis. So if we look at asthma and the environment, it's important to understand that there are direct correlations to what we're exposed to and health outcomes with asthma. This is a study published in the International Journal of Environmental and Public Health, and it investigated proximity to roads as an indicator of air pollution exposure and its association with childhood recurrent wheeze and asthma. This study was completed as a prospective cohort study of 921 infants hospitalized with bronchiolitis and recruited from 12 states. Participants were recruited from 12 sites in the fall and winter of 2011 to 2014, and children from Orlando and Polk County participated in this study. They found that for children living within close proximity to a major road, they had a higher risk of developing recurrent wheeze by age 3 compared to kids living greater than 300 meters away. And the risk of recurrent wheeze diminished as distance to major roads increased, suggesting a linear relationship with recurrent wheeze. So many of you took I-4 to come here today. It occurs to me that in this area, we are exposed to a lot of road pollution, emissions from cars, and that can absolutely impact the severity of asthma that we're seeing in our patient population. So in 2019, 99% of the global population resided in areas where the air quality did not meet the World Health Organization guidelines. Air pollution is a complex mixture of particles and gases. And the air pollutants for which the Environmental Protection Agency has set national ambient air quality standards include particulate matter, ozone, carbon monoxide, nitric dioxide, and sulfur dioxide. Particulate matter can be divided into 3 categories based upon its diameter. And fine particles, which range from 0.1 to 2.5 microns, can be particularly dangerous because they're the right size to settle in the lungs. And in fact, when we design aerosolized medications for asthma, we try to get them to that size because we know they're going to the alveoli and to the bronchioles. So when you look at common sources of air pollution, they include, again, car emissions, industrial factories, forest fires, vehicle exhaust, heating combustion, cooking indoors is a source of indoor air pollution, smoking, incense burning, vacuum cleaning, sanitary and hygienic sprays, clothing residues, and animal dander. And children are at high risk for asthma exacerbation induced by air pollution exposure. And this may be due to their unique anatomy and their physiology. Children breathe more quickly and inhale more air relative to their body weight than adults, which renders them more susceptible to the impacts of poor air quality. So in this study, they looked at asthma and how it's affected by air pollution. They looked at epigenetics and genetics, but also they looked at air pollutants, and they were able to correlate it to a mechanism of particulate matter 2.5 microns and ozone being potent oxidants that can induce oxidative stress, initially by reactive oxygen species, leading to the production of inflammatory cytokines such as IL-6, IL-8, and IL-1 beta that lead to type 2 asthma. So this was an interesting study looking at lifelong exposures to air pollution and greenness in relation to asthma, rhinitis, and lung function in adulthood. It was actually completed in Norway and Sweden. They measured greenness by the normalized difference vegetation index, which is actually a widely used metric to quantify health and density of vegetation using sensor data from satellites. And in this study, they analyzed 3,500 patients, and they looked at individual mean residential exposures to nitrogen dioxide, particulate matter, carbon, ozone, and greenness. The average exposures across susceptibility windows 0 to 10 years of age, 10 to 18 years of age, lifetime, and adulthood. And they reviewed geocoded residential addresses to each year from birth onwards. And they found that there was actually a correlation between nitric dioxide, particulate matter 10 microns and more, ozone, and ozone exposure in childhood and adolescence, as well as in adulthood. I wanted to segue to work-related asthma because this too is something that's affected by social determinants of health. And as we manage kids and adults, we need to mention it. Of the estimated 170 million US adults working in the past year, 13 million had asthma. Among workers with asthma, an estimated 6.9% had work-related asthma, workers with work-related asthma were significantly more likely to use preventive medication and rescue inhalers and to experience adverse health outcomes and lost workdays than workers with non-work-related asthma. And so the highest prevalence of work-related asthma is in people living in the Midwest, in males, those with no health insurance, and workers age greater than 55. And the economic impacts for work-related asthma can be amplified for workers in low-wage jobs with little safety net or power to demand change in workplace exposures. So this study looked at occupational asthma and found that it's an important contributor to disparities in respiratory disease affecting financial status, healthcare access, and exposure to hazardous substances. And it's important that when we talk to patients and their parents, we assess the occupational exposures that they have, that we ask, what kind of work do you do? Do you think that breathing problems are related to your work? And that we also look at the chronology of their job history. I recently saw a 17-year-old who had been admitted for pneumothorax and new diagnosis asthma, and he's a welding student. He has been welding for about 3 years. He loves it. He was graduating. And I had to share with him that we would have to implement some protections because the smoke and the particles created by welding were a risk for him given his diagnosis of asthma and his history of pneumothorax. So it's important that you integrate an occupational history if you're looking at patients with asthma, that you consider how respiratory diseases are affected by both structural and individual level factors in occupational exposures, and that you develop treatment approaches to integrate workplace exposures into disease interventions. So again, we're looking at social determinants of health, and they're broad, and we have to use social determinants of health as a prism to look at asthma overall. Health literacy is a major part of social determinants of health, and health literacy includes health-related knowledge, reading and writing, fluency, oral communication, quantitative skills, navigation, and information seeking. And this has been studied in pediatric asthma, and we have found that there is an association between worse asthma control in children and lower parental health literacy. This is a review study that was published in 2023, and it acknowledges that social and structural determinants of health lead to low health literacy in approximately 36% of adults in the US. They highlight that there are many different realms when you evaluate health literacy. There is the individual realm where personal health literacy, asthma knowledge, and skills impact outcome, but also there is the organizational realm where we as hospitals, clinics, and healthcare facilities can impact health literacy by the policies that we develop. There is the community realm where churches, where schools all can impact how we educate about asthma. And then lastly, public policy, which can offer us broad strokes, but how that is implemented really depends on the community, the organizations, and the relationships that we have as providers and people working in the community. So it's important that you assess health literacy. One of the things that we offer in our clinic is an asthma control test. And so this is given before the patient sees the provider. It helps to prime the patient to think about how their asthma has been controlled over the preceding 4 weeks. I don't know about you, but I can't remember what I had for dinner last Friday. So it's hard sometimes when you ask a patient, well, what symptoms have you had? They're expecting you to tell them how to control the asthma, but you need to know from them the symptoms to assess control. So I would encourage you to consider some of these health literacy assessment tools if you're not already using them. Test of fluent health literacy in adults is something that you can use to understand how well the parent or an adult is actually able to use the information and synthesize it to create a positive health outcome. If you give an asthma action plan to a parent and review it, but they really aren't able to understand what it is saying, then you've not helped the patient. So as I've looked at our outcomes in